Hello and welcome to DrugsPlus. Whether you're here for exam revision or just general interest, I hope you find this video useful. If you do, please give it a thumbs up and subscribe to support this channel so that I'm able to continue creating this content. In this video, I'm going to discuss gestational diabetes. Gestational diabetes is defined as any degree of glucose intolerance with onset or first diagnosis during pregnancy, usually resolving shortly after delivery. Symptoms for an expectant mother includes hypertension, preeclampsia, a form of gestational hypertension, caesarean section, and urinary tract infections, while symptoms for the fetus include macrosomia, a large birth weight, risk of birth injury, hypoglycemia, and respiratory problems. Gestational diabetes affects 10% of pregnancies and is caused by the effects of pregnancy hormones, progesterone, cortisol, oestrogen, prolactin, and placental lactogen. Although progesterone and cortisol inhibit the binding of insulin to its receptor, estrogen enhances it, so these effects are balanced out. However, progesterone and cortisol also inhibit insulin receptor substrate, and therefore the entire downstream signaling cascade of insulin receptor activation. For more information on the response to insulin activation, you can see my video on type 2 diabetes, the link for which I will provide below. Additionally, these hormones also inhibit the translocation of GLUT4 molecules to beta cell membranes, meaning glucose is unable to enter the cells and the release of insulin is not induced. So overall, progesterone and cortisol provide both insulin resistance and reduced insulin secretion, the severity of which both increase over the course of pregnancy. This results in sustained hypoglycemia. However, this increase in blood glucose concentration is actually tactical. It means that more glucose is available to cross the placenta to the fetus. In most expectant mothers, the pancreatic islets of Langerhans adapt to compensate for this in three main ways: increased glucose-mediated insulin secretion, increased serotonin secretion, and increased beta cell mass. Prolactin and placental lactogen both act on prolactin receptors on beta cells. The activation of these increases the activity of glucokinase, one of the key enzymes of glycolysis. This increases the rate at which glucose is processed by the beta cell and therefore the rate at which insulin is secreted. Serotonin is secreted from beta cells in large quantities during pregnancy, which activates HTR3 receptors and opens them. These receptors are usually cation channels, which once opened facilitate a small sodium influx down its concentration gradient. This induces a slight depolarization of the beta cell, effectively lowering the threshold required for insulin secretion. And finally, prolactin receptor activation also activates STAT5, a transcription factor which enters the nucleus and activates the transcription of survivin, a protein inhibitor of caspase, the primary enzyme responsible for apoptosis, meaning the rate of beta cell apoptosis decreases and beta cell mass increases. However, in women with gestational diabetes, the islets fail to undergo any of these compensatory mechanisms, the reason for which are unknown. Why? Because human islet samples from pregnant women are difficult to obtain, as these would have to come from women who died during gestation. Not only is this rare, but also presents discernible ethical concerns. Thank you for watching this video. If you found it useful, please give it a thumbs up and subscribe to support this channel so I'm able to continue creating this content. I'll be back with more pharmacology videos soon.